from here, we move into a mentorship phase where you'll really be paired up more so at this time with Eleanor Sedge, and she's one of our WET coordinators, and hopefully one of the students that we have right now as well, because the idea is there's a volunteering student that goes out at the same time. What Eleanor does is she'll take you out and she'll walk you through, last week we went through visit 1, for example, and she'll sit at the very first visit with you with a client that she thinks would possibly be a good fit for you. And she'll go through the whole interview with you, and before that she'll meet with you and say, are you comfortable doing any of these pieces? Did you want to try some? Like, do you want to walk into my story? Do you want to just dive in and do it from the get-go? And then from there she'll support it. So I know, for example, when I was covering for Eleanor one time, I went on a second visit with one of the volunteers, and we kind of tag teamed. So I sat and played the role of the student and did all the typing and all the technical stuff. So it's a really good way to kind of dive in and just get your feet wet. And really it's just about sitting down and having conversations. So if we just think about it as that and trying to achieve some objectives from it, we're fine. So, you know, it does take a little bit of time for us to put all of these pieces into play, and the more we see it and the more we go with clients, we're good to go. So one of the things last week that we went through was the skills and talents survey. Did anybody go home and do their own, or did you finish it while we were here last week? And for the skills and talents piece that we go through, although it feels sometimes like a task, we sit and ask people, what do they enjoy? We have a tendency as caregivers to say, let me do that for you, right? As opposed to saying, would you like to help me do it? Or is there anything that you would like to help? Can you give me a hand? And sometimes it's easy to forget how valuable that is to individuals, especially if they themselves have spent their lives caring for a family or anybody else. So the skills and talents piece is just very important for people as they're going through a disease process, whether it's early stage or later stage, to stay involved in activities that they feel they're contributing back. So that's what that piece is all about. So that's the link in the skills and talent side of things that I just wanted to bring everybody back around. We had also talked about the quality of life survey last time, and I brought up a copy of one of the reports that people would get back when they complete this, and we started talking about goals at the end of our session last week and how we would use that information to start the development of goals. So did anybody actually do the quality of life survey and bring it back, or no? It is a really good experience, and you know a good way to do it if you don't want to do it on hard copy. We actually have a survey link, so when I send the evaluation form to Jen to get a response back from you guys on the classroom training, maybe she can send out the link, and I would just encourage you guys to go through it. It's a really good experience. And if you want a report, then you can identify in there that you would like a report yourself, and we can, that gives us permission to actually run one. If you don't, that's okay too. There is a button at the end of that survey that makes you run off every single answer that you pretty much did for the whole survey, which is kind of cluttery, so we actually have to go into a different area to run the report. So, okay, so starting point was that. All right, so let's flip to, in the section of your binder that says coaching, back to your Sharing My Journey Coach Workbook and Training Guide, if you remember from last week. This is kind of the main thing that you want to have available when you go out on visits, because it's your reference guide. It's like having a dictionary, and also provides you process items. And then, of course, the other document, the Lifelong Care Plan for Jane Doe, is the sample completed one, which at the end of the visits we actually present to people, so that they have that available, they take it with them to the hospital, or they make sure it's available if EMS happens to come, and helps them walk through all of that. So we're going to start with, first of all, does anybody have any questions? So as with any visit, when you start the next visit, before you go out, you actually look to see what might be missing from the first visit. And you start by trying to fill in any of the gaps that were missed from that previous visit. If it's the third visit, would be the second visit. And of course, you do the usual introductions that you would do at any other time. If you flip to the next section, you're going to see your client binder. And that's just what I'm going to tell you is that this is a resource that now we're going to introduce to the clients in terms of the development of their circle of care. So if everybody can flip to this document that's called Sharing My Journey, My Circle of Care Net Workbook, which is under the tab that says Client Binder, and just pull that right out of there. I know it takes a bit to find it.
Is it 1, 2, or 3? We're doing it.
So right now you should be under the tab that says Client Binder. So in your workbook it would say Client Binder.
Is this what you want it pulled out?
Yeah, just pull it out, but it's Sharing My Journey, My Circle of Care Client Workbook. All right. So on page 39 of your Coach Workbook and Training Guide, the 65-page document, it talks about something called your care circle. And the care circle is all about having a visual representation of the people that are around you, that support you day to day, support you on a weekly basis, a monthly basis, an annual basis. How are we going to figure out who's in our care circle? If you flip to page 41 of the Coach Workbook and Training Guide, the 65-page document, you're going to find responsibilities, hours, and location of regular care, so if someone has formal care. And there's a number of these documents that we would encourage people to fill out. And the reason for that is we take that information and we actually have them create a visual representation of their circle of care. So when we go to practice in this session, I don't want you guys to sit and go through this big lengthy process of filling out all of these boxes. As you can imagine, it would be fairly time consuming. What we actually ask clients to do is we actually ask them to take that document and to fill it in themselves. And then we would take that information back and we would populate their booklet rather than spending time during a visit just doing that. So for the purposes of this break-off exercise that we're going to have shortly, I'd like everybody to use that workbook that you pulled out, Sharing My Journey, My Circle of Care Client Workbook. And I'm going to give you a very simplified thing to do today. On page 9 of that 16-page document is a Circle of Care worksheet. And what I'm going to actually have you guys do is I'm going to actually have you practice in terms of an interview process to learn and understand what someone's circle of care is and actually write it right on this circle of care. Okay? So what does that mean to you? If you look at the very top of this on page 9, it tells you what you're going to put on. So who's important in your life? So if I were to do this for me, I would look at this picture and I would have my son in there. I would have my son under family as somebody that I see on a daily basis, and I would identify that this is someone that I see daily. I'd also have my father in there, my brothers, my sisters, any of my aunts and uncles, and whether I see them daily, weekly, monthly, or during the year. If those are people that I feel are people that are part of my life. Now I know many people have different family situations, so if there's relatives that you never ever see and don't ever want to see again, you're not going to put them in there because they're actually not probably what you're seeing as a part of your circle of care. That might be a Steve thing. later on down the road. A counseling session. And then you'll also see a section on friends. So then I'm going to write people that are friends of mine that I consider to be an important part of my life. So I might put my friend Gail, I'll put my friend Sharon, I'll put my friend Matt, different people, and how much I spend with them and whatnot. So it gives me an idea of who's around me. And then others. And so others could include who? Neighbors, yeah, absolutely. If they're not like who you consider friends, you consider them kind of acquaintance, casual types of neighbors. Yeah, that would work. Anybody, any others? People that you volunteer with or work with, that you consider them colleagues, but not like friends where they're part of an intimate part of your life, I guess, or not intimate, but a more connected type of part. Yes? Anything else? Physicians, yes. Physicians could fall in here in terms of the circle of care. Yes, absolutely.
Your pastor?
Yeah, yeah. Your pastor. So similar to what you were saying, your church community. Yeah, members of the congregation. Pets. Pets is another one. So in terms of my circle of care worksheet, if I look at this as this is me and these are the people and items around me that are important, then that's what I'm going to have in here. You'll see farther down connecting with your community one. It breaks it down into specific pieces. So people can actually create it so they have one form for this and a second one where it's just about your community. But for the purposes of what we do, we use actually an electronic thing called Eugenie, and we actually populate one, and we put everything on one. So that's why for this exercise, we'll have you guys do one. So it's actually not too difficult, but the thing is to really, when you're interviewing your partner, to draw out from them people that they might have forgotten. So I think at the very first session, I told you about how we had been doing training, and one individual said, here's my sheet. It's me and my dog, right? And this is someone who's volunteering, right? And so we kind of worked through, well, who else is involved in your life, right? And kind of identified more. And people start to realize who's around them. And that also helps prompt people to think about when they're finishing this piece, right? So from this, they can now develop the details in here. Okay, so you're in the center of the circle. You have the people closest to you that are the ones that you share your greatest life secret with and your decision making, as you said, closest to you. So those daily kind of, it usually becomes your daily, weekly, monthly, and yearly. It spreads out from the center. So the people that you see the least amount are farther out. Yeah. Just some very basic things as well, so we can kind of move along through the visits. I'm not going to have you guys practice every aspect. On page 46 is really a piece that is filled in as an information piece, but doesn't really require a lot of discussion or interviewing. It's more about adding in here, what sort of technology do you have in your home? Why are you using it? Are you using it? And who's responsible for making sure it works properly? So if you have oxygen, someone has oxygen in their home, right? What's it for? I use it when I'm having difficulty breathing, for example, if they're not using it all the time. And who makes sure it runs properly? It could be John, my next door neighbor. It could be the actual company. So any of those things, feeding pumps, any of that stuff, you would just list there. It's a task piece, so I just want to kind of go through that. And then there's also a piece here for a care schedule. Not everybody's going to have a care schedule, so I want to make that really clear. If someone has nursing care plans or medications, it's very complex, that type of thing. Those are all going to be added in here. We don't recreate anything. We're basically saying, here's your information, let's put it all together, and it's here for everybody to be aware of. Okay, and so page 47 gives you a little bit more of that information. And then we're going to stop there before we move on to self-help resources. I really want you guys to dive right into just, again, practicing, having conversations. Do the circle. So you're going to sit down, you're going to introduce yourself. Hi, my name's blah, blah, blah. You remember me from the first visit? Oh, yeah, I remember you, Paul. Oh, yeah, you're great to have come here. Right? Would you like a cookie and some coffee? Right? Those types of things. And then you're going to say, okay, well, did you put your Kool-Aid form up? Right? You're going to do a few of these little reminders. Did you get a chance to fill this out, get it on your fridge? I had some trouble. Can you help me fill it out or whatever? So those types of things. And, of course, your card. Right? Here's how you get a hold of us. Right? Do you still have that available? Oh yeah, it's on my fridge. My son knows, right? So you're just you're confirming that they've got a good knowledge of the information that you went through with them before. Just those things that are always important. I can't tell you how many times people called when we were at CCAC, called various times, and people say, I don't know who came to visit me. And, you know, it's not that people aren't introducing themselves. Of course they are. People forget, right? They can't find the thing, right? So the more you can reinforce, yeah, my name's Paul, and yes, right, here's the card. Okay, so it's a good visual representation, and it gives, in a glance, the information to your quarterback or your partner, whoever is helping you continue to do the planning for your needs. To have that representation. It also actually helps us to think about how are we filling out that table. You know, the table that I showed you guys on page 40, you have it in your coach workbook, page 41 to 45. It's also in this package. It's the piece where people were asking them to take that to do for homework. So in there, for example, is informal care. So I'll skip formal care because everybody kind of gets that. It's a task, right? Who are my physicians? Do I have Red Cross come in and provide bathing to whomever, right? So those types of things. But for informal care, think of it like this. When you're healthy, it's easier for you to think about who's going to be around you to support you if something happens to you. So if you get in a car accident and all of a sudden you're in the hospital and you have to be discharged, right? What do they say? They say you need to leave by the end of the day. You should have your plan right, organized, all of that thing. Hopefully they've talked to you in advance and told you you're going home tomorrow. And if you can't do that, then, you know, rest home's an option, right? So this actually, filling out your informal care table is about saying, who would cook meals for me, right? In my car accident, I actually fractured my hip and I can't really move well enough to stand in the kitchen and cook for myself. So I know that my friend Diane is going to come and cook meals for me. I've not only written it down here with her name, her phone number, but I've called Diane and I said, if this has ever happened, do you think this would be something that you could do for me? So now you've got early planning so that people are prepared when things that we don't ever think are going to happen to us suddenly happen to us. We know, again, back to the whole family thing, it's easy to kind of say, well, if I got in an accident, I'm sure my brothers and sisters would take care of me. Everybody's kind of got their own life, right? So, I mean, I can say for me, my son keeps me very busy. I'm sure Christy feels the same way with her daughter. I'm sure you guys feel the same way with your spouses or all of the activities you're doing, right? You're busy. It's not as easy to say I can drop everything and come and take care of Diane, who was in this terrible accident, right? Not saying that we wouldn't, we'd try our best, but to plan ahead actually distributes all of the activities in advance in the pre-planning. So that conversation with the whole circle of care worksheet helps the person think, okay, I think I can take this and finish this, right? So you're going to go through. So now, are you comfortable if we leave this with you, and next week when we come back, we can pick that up, and we'll just go through any gaps or things you didn't understand, and then we'll take it back and we'll input it in all for you, right? It was very nice listening to Sandy and John, because John actually kind of went a little further and talked about communication and who would or wouldn't want to be advised as to his condition, which is a very important piece. So farther on in the booklet is a whole piece on communication. Who's responsible for communicating? But also to push that further, who do I want information communicated to? And having it written down is the best way to make sure that the people you don't want to get the information aren't getting it, but the people you want to have the information aren't somehow insulted. I get this all the time. Insulted because they never knew, right? And it's only because someone didn't know to tell them, right? And so I think many of us can relate with, I wish I had known so-and-so had been in the hospital. Because you're shocked all of a sudden they'd passed away, because I would have made sure that I could get out and see them, right, for one last time. Because nothing's worse than all of a sudden you've not had the opportunity to see them for that one last time and they've passed away. So I know that's happened to me before, and people will, in their best abilities, try to let people know and think it's somehow going to get out to the right people, and that just doesn't happen. So thank you, that's a really good point. Everybody remember seeing this last week? Quality of life report. So when you do your quality of life survey, you get this report back. And from this report, we've built the quality of life plan. So everybody will recall page 25 of that 65-page coach workbook document is where the plan's been started actually by the student from the information that comes out of the report. So the second visit seems short in terms of, I guess, task work that you're doing. When you look at it, it's all about who's around you in your circle of care, what technology stuff, do you have a care plan if you need one at that time. Then we'll go into the last piece in a minute, but really it's that follow-up. Probably takes you a half an hour to go through the stuff from the first visit, because you're now continuing to build on the goals. So in the goals section, you can see how, for their concerns, they had mobility problems. So we know that that's a concern for them. So we know we need to identify as a goal how to help them correct that problem and get them on the path to correct it. So the conversation about the goals needs to continue at this visit as well. So I kind of talked about the paramedic piece and whatnot, but I wanted to bring that back up because I know sometimes this is one of the most challenging pieces because we want it to be so successful. So if you're building a goal about mobility, and as I said, the students will tend to formulate a goal that's achievable. And I want to increase my ability to walk not just 5 blocks, but over the next 3 months I want to increase that to 20 blocks, for example. That I've written that in my goals, and who's going to be there to motivate me. Maureen's coming to my house to get me out of bed and take me down the street. We already identified that. Thanks, Maureen. And so Maureen being a part of my team is actually going to fall in my team's role. So when you look on page 25 on that quality of life plan, in that example I just showed you about the desired goal of increasing my mobility, actions my team can take, Maureen will come three days a week or whatever it is to get me out of bed and take me down the street, and we'll continue to walk, right? And what's the date completed, right? We usually put a 6-month period in there, but it could be 3. What actions can I take? Those types of things as well. And they may be simple things like I can start doing simple chair exercises or bed exercises depending on my level of ability to actually move. Maybe I'm using a walker and I want to stop using the walker and progress to the use of a cane. Maybe I'm using a cane and I want to progress to not using anything. So there's all sorts of things that we talk about, and the idea of having that professional student there is to help their learning and their building on their knowledge base as well as you guys. In 6 months, when you call back to do a check-in visit, it might be about, so how far have you made it in your goals, right? And oh, wow, you made it up to 8 blocks. It's okay that you didn't quite make the 20 blocks. Let's kind of look at reworking those goals. So it's always kind of keeping that positive momentum going. And in our minds, we might think, oh, that's never going to happen. We have to keep that in the inside part of us, and try to continue that encouragement and that positivity. Yeah. You want to redirect things back to them to get them to draw the conclusions and draw the plans on what would work best. So absolutely perfect in terms of how you're addressing it. You're putting it back in terms of these questions. And everyone will be different. And that's where we don't expect people to go out and they feel alone. That's where your coordinator comes in, your volunteer coordinator, or any of the WEC coordinators. I'm actually going to show you a video that was developed by McMaster University from their Health Tapestry project when they were creating their volunteer training. They created a number of video segments as well as quizzes and whatnot. Don't worry, we won't do the quiz. But I do want to show you the video because I think it's a really good portrayal of what you might actually come into contact with when you're out there. And although the end is a little bit different in terms of how we would have people support.
Mrs. Johnson is an 81-year-old woman. She lives alone and she has 2 kids, but they live in Chicago and Sudbury with their families, and she only sees them at holidays. I also found out that her husband passed away in the last year or so, and this is going to be her first visit with her.
Hi, good morning. We're with Tapestry. We have an appointment with Mrs. Johnson.
Oh, that's me.
Nice to meet you. I'm Nadine.
Oh, nice to meet you.
Hi, Jessica.
Nice to meet you.
Nice to meet you.
Come on in.
Thank you.
Fine when we arrived. We made it through the whole daily life activities survey and part of the quality of life survey before we noticed something was wrong. So question 4 in the quality of life survey. What best describes your pain or discomfort today? I have no pain or discomfort. I have slight pain or discomfort. I have moderate pain or discomfort. I have severe pain or discomfort. Or I have extreme pain or discomfort.
Severe.
Sorry to hear that.
What's so funny?
Oh, I'm sorry. I'm not laughing. I was just smiling.
Okay, are we okay to go on to the next question?
Agreed.
Okay. Alright, so what best describes your anxiety or depression today? I am not anxious or depressed. I am slightly anxious or depressed. I am moderately anxious or depressed. I am severely anxious or depressed. Or I am extremely anxious or depressed.
I'm severely depressed. You see? That one? He thinks he's better than me. My life is not a joke for you.
I'm sorry, Mrs. Johnson. I really didn't want to make you feel that way.
My first instinct was to say, calm down, Mrs. Johnson, but I thought that could sound a bit judgmental. Okay, so we have a couple options here. We can take a little break for a bit, or we could go on to the next question, or if you want, we can end the visit here and we'll come back another day. What would you prefer?
It's fine. Go on with the next question.
Okay. Alright, so the next question is on the same scale, but it's the big scaling question. We want to know how good or bad you feel your health state is today. So on a scale of 0 to 100, with 0 being the worst possible health state you can imagine, and 100 being the best, where would you say you are today?
25. Or even 20.
A 20 then?
to find out what matters to you. So how can we help?
Sometimes I think if I would just die, it would be better for everyone.
Are you planning to hurt yourself?
No, not really. But if I could drive, I might drive down to Niagara Falls and just jump off.
Do you have access to a car right now, Mrs. Johnson?
No, not anymore. And I wouldn't really do anything at this point. It's just something I think about.
If your feelings get worse, you can always call your clinic. We also have a list of local 24-hour crisis lines you can call. Would you like to take down one of these numbers?
Oh, I do that one. I'll write that down.
Okay, we'll also inform our volunteer coordinator about what we've shared, and she'll inform your clinic.
What? I thought what we were talking about was private.
It is private, but Tapestry always works between us and the clinics too. So as you know, all the surveys and everything we're filling out go back to the clinic. And I'm sure your doctor cares about you and she'd be concerned to know what you've shared with us today.
Okay, I guess it's all right.
Okay. Can you agree to keep yourself safe until you hear from your clinic?
Yes.
Hello? Hi, Jessica. How was your visit? Great. Yes, I saw that alert. Absolutely. I think it's imperative that we contact the clinic and let them know. They should be following up with her.
That concludes this vignette.
Talk a little bit about this this mental health video. So first of all, I know people probably aren't familiar with the McMaster Tapestry project, which was a project they did or started about 5 years ago, and they did it with primary health care team, and they had a student and a volunteer pair go out together, and were able to, through the use of a quality of life survey only, not the depth that we do here, but only through the survey, they were able to identify concerns and issues about clients that they could immediately transfer back to physicians, nurse practitioners, whoever they needed to at the clinic. So it was specifically honed in on one clinic, and I can't remember exactly what area it was, and so it was really just done in that small piece. We're much more ambitious, so we've actually taken that one small piece of a volunteer-student pair, starting with a baseline quality of life survey or assessment, if you will, and then expanding it further to help them with their lifelong planning. So it's not just one piece, it's many pieces that people need to think about in terms of themselves and their planning. So in this scenario, they talk about, you can see all their fancy electronics that they have, which we don't have, because they had someone who donated hundreds of thousands of dollars, and they went out and bought all these tablets and cell phones and all sorts of stuff, so we don't have that. So what we do is we just ask that people call us. You can ask the individual if you can call from their phone, or if you have a cell phone, or the student does, and just call and let the coordinator know. So there's always someone available that can be called just to say, I'm a little bit concerned about this person, and then we can do a follow-up call back and talk to them or whatnot. You'll see in the booklet itself, we actually automatically put the crisis line in there so that everybody's got it in case they ever need it. In terms of what they need. So the Hotel du Healthcare has a 24-hour line that can be called, and that crisis line's in there. The other thing that you can also ask is there a friend or a family member that we can call that could come and see you and talk to you a bit more, or talk to you over the phone or whatnot. because you're not going to know all the underlying behavior of someone, you know, if this comes up. It might be someone who does, you know, who does this all the time, and the son or the daughter knows, and they're going to call, and they know how to kind of resolve the situation. So really, that's essentially, it is about making sure that they're safe before you leave. You've kind of delved a little bit into it, making sure that they're not going to do anything immediately. I have to say, we've never had any issues like this, so we actually don't have a lot of people with severe mental health issues that we're currently tied into at this time. Okay, does anybody have questions? I love that it gives you a bit of a scenario, and again, I apologize for the technology piece. Yes, Paul.
Am I right to assume that because of what the lady said, that by law you're required to go to the clinic to report because there's a possibility that she might have been thinking bad things?
So that's why you would contact the coordinator to let them know.
And let them say, hey,
yeah, exactly. Okay. So that's a piece that you would need to do. Okay. Oh no, this is not the thing that I wanted. My apologies again. Okay, so let's go through a little bit about mental health. So in this section, your second last tab, second last tab. So the last tab is full of resources. I shouldn't say full. Has some sample resources. The second last tab is really one page, and it's called Sharing My Journey, Mental Health in Older Adults. It's just a one-page document. Your second last tab in the binder. Oh, is yours missing? It's just one page. So, yep, I can see you, Phil. Odd. Okay, so yeah, so it is missing. I'll give you my copy after. You're certainly welcome to have my copy. So in this, the statistics are right here for you to see. 20% of older adults experience mental illness. Depression, anxiety, and psychotic disorders are most common. Both depression and anxiety in older adults are associated with suicide attempts. And by the year 2020, 4.4 million adults will require treatment for substance abuse. I don't think that's a surprise. I think people can already see the effect. I think there was one physician from downtown Toronto that said the Canadian stats are staggering, that 9 people die every day from substance abuse. And that's constantly going up and up, so, which is very unfortunate. Recently in the Windsor Star, I know probably a lot of people read the Windsor Star, you saw the information about the downtown mission and the homelessness crisis there, and Ron Dunn was again on the radio today talking about how full in terms of capacity they are. They started out with, I think it was around 80 beds, and they've had to actually expand to almost just over 100. And a lot of them are substance abuse people that have no place else to go, right? So it's very unfortunate. Men are 4 times more likely to complete suicide with those 59 and older. And that's because men generally pick really brutal ways of doing it, like shotguns, for example. So that's why they're more successful, whereas women will pick, pills or things like that, where there's, often a chance of recovery if someone finds them in time. There's more information on this piece. Really, the key thing is, in terms of visiting people like this, the first thing you need to do is, just like they did in the video, just try to make sure you're calm and you're trying to help them remain calm or become calm. If there's distracting stuff in the background, people, noise, that can agitate us all. It will agitate people more, so like TV's on, turn it off, or the radio, or those types of things. And of course, we never want to assume what the problem is or be judgmental. In 1980, Dr. Ron Diamond did some research in terms of misdiagnoses. He specifically focused on mental health, and got some information about reasons why people are misdiagnosed. Before we talk a bit more about misdiagnoses, does anybody know what the percentage overall is for people being misdiagnosed? I don't know if I said this in the first session or not. No, for all diseases. What percentage of people are misdiagnosed when it comes to medical diagnoses? Go to the doctor, you say, this is wrong, this is happening to me, and the doctor says, here's what you have.
I'll go for 60%.
That optimistic 60% of the time they're wrong. You're close, it's 40. So 40% of the time, overall, physicians are misdiagnosing people. And that means if you said, well, what about mental health people? If you took that percentage and shifted it over, you can very easily say 40% of people are misdiagnosed with a mental health disorder. I would actually say that people are misdiagnosed more frequently than that 40% with mental health disorders. Does anybody know some of the underlying reasons why we could potentially, our behavior be misconstrued as a mental health illness? So those are examples: depression, loneliness.
Sometimes pills or the drugs you're taking can really make you go to not good places.
Exactly, so that's a really important one. So pharmacological interactions, people are taking medications that their physician prescribes to them. They're also taking different herbal medicines or things like that. Maybe the doctor's not aware of them, and there's some sort of interaction which causes what looks like a mental health illness. Diane?
Someone's diabetic, they get high blood sugar or low blood sugar.
Exactly. So any of those things where you could have a high blood pressure, or sorry, high blood sugar or low blood sugar, like diabetes. Okay, yes, Jenny? Urinary tract infections are huge, huge. So they cause us to start having cognitive or mental health appearance issues, and they automatically get treated as with something other than what they should. So looking at the underlying cause of why someone is behaving differently is so, so important. What else? So good one. Similar to that, what's one of the reasons the elderly often end up with urinary tract infections? Often because they're not drinking enough. So dehydration is a huge one. People have heard of the tea and the toast diet. Tea, coffee is dehydrating. So the intake of water is very, very important. So if you're dehydrated, often you'll get UTI, urinary tract infections. Also with dehydration, or so lack of fluid intake or lack of dietary intake, is malnutrition. So as soon as your electrolytes start to go out of balance, if your potassium is too high, any of these things, those can be misdiagnosed as mental health illnesses. Head injuries is another one, especially in the elderly. Often they're not going to say, I fell and hit my head, because people are fearful that if my daughter finds out I fell, they're going to think I need to go into a home and I want to stay where I am. So they're not always forthcoming with the fact that they've fallen and injured themselves, and they're not always visible, right? Especially if you hit your head, you know, and you're covered with hair. Any other ones? Can anybody think of any others? So we've got kind of what I call the ones that are really common ones. Yes?
Isolation kind of brings that too, doesn't it? The more isolated they are, the more they can have.
Yeah, so isolation definitely can lead to that for sure. And it also, isolation leads us to not really, because we don't practice social interaction and our ability to talk to one another, we start to lose those basic social skills. Makes it harder to pull ourselves out of isolation, start to hear things, see things. As we lose our hearing or our vision, we start to imagine things and we all of a sudden get diagnosed as having dementia, right? Because in the middle of the night I saw something brushing by the window, it was dark, I couldn't hear well, I didn't have my hearing aids in, and you know, every night I'm calling the police because I'm scared. They start to say there's something wrong with this person, and very, very easily misdiagnosed. Another one that happens very frequently to women as they start to become menopausal. There's hormone imbalances will cause kind of these mental, right? This mental health diagnosis, and sometimes people will say, well, we've got a temporary anxiety disorder as a result of, you know, them going into menopause. So at least they don't perform lobotomies on us anymore like they did in the 60s and put us in the... So just something for people to be aware of, and I guess that's why we tend to focus on those very basic things like exercise, like movement, being involved in social things, and diet. All those basic things to keep us healthy are so important. And once you're diagnosed with a mental illness, if you're incorrectly diagnosed and all of a sudden they've got you on medications, a lot of times those medications have a cumulative effect in your system. And as we age, it's harder for our bodies to pull those medications out. So even as we try to kind of wean ourselves off of those drugs, it becomes very challenging. A friend of mine, when she was going into menopause, she said, oh my gosh, I was crying all the time. And I felt like I was going crazy. And I finally, you know, my husband told me to go and get something from the physician. And she said the drug, and of course the drug they put her on was cumulative. And she said, oh my gosh, I was just so spacey. Yeah, you don't have to directly ask them that question if you're not comfortable. You know the coordinator who's going to follow up. If you say, I think they're going to hurt themselves, I'm really concerned. Yeah, then the coordinator is going to follow up, and they're the one with the professional background that are quite comfortable to say, are you planning on hurting yourself? So that direct question, I hate to say it's almost like a liability thing, right? But it's almost required of professionals to say, I very directly asked them, are you planning to hurt yourself? Because I needed to do my due diligence to make sure I was trying to help them the best that I could. Really, it's about connecting them in with whatever their support mechanism is.
But when you look...
You can, yeah, you know, if you don't have a cell phone, do you mind if I use your phone? I just have to make a call to my coordinator. Yeah, and they'll let you know. Usually people who are saying things like that, actually that's their way of looking for help, right? It's a drastic way of looking for help, but so they'll probably be like, yeah, and into their thoughts. Okay, so if we can, let's shift into the third visit. So on page 53 of your 65-page coach workbook and training guide, it's the color one. Yeah. Yeah, you've got it right there. So yeah, if you pull it out, I find it's easiest if you just pull them out of the binder. Page 53, page 53 of 65. It's number 10, the prevention and escalation plan. So as with visits 1 and 2, you're going to go start your third visit with the previous knowledge base. What have they done? The whole piece about their goals and all of that. So you're going to carry on all of the stuff you did before. You're going to get that table that they've finished or their loved one has finished with them. If they haven't done that, that's where you need to sit and do it with them, which is time consuming, but it's a very important piece to use to finalize their goals. The other piece that needs to happen is this prevention and escalation plan. So you can see again, on the top of page 53, it says refer back to section 4, our concerns, which is where all the concerns were listed from the report that I had up earlier. And you can see the fourth line down where it says distress, and the distress line is right there. So the phone number for Hotel de Grace Healthcare for their 24/7 line is automatically there on all of them. That doesn't mean that this person has necessarily been predisposed to having distress or anything else. It's just a safeguard, and it's information there. They might have periods of distress where they've learned other mechanisms to contact certain people. So I might call John. John's the guy that helps calm me down when I'm in a state of distress. And he runs right over because he's retired and he's got time and he's not far from me, right? So he's listed on my table for that, but I also have it listed right here. And then what do I do after hours? My after hours isn't always, let's call 911. My after hours might be, I'm going to call Lana, because Lana's happy if I call her in the middle of the night. She doesn't mind. She's a bit of a night owl and she's up all night watching Netflix. So Lana might be in my after hours plan. That she's the person that I go to.
You could want to call around 2, 3
These items that are listed here are standard items, but again, people may not be predisposed to feeling lonely, but we have it on there as an item because it does tend to be a piece for our population. What do I do when I'm lonely? I call my sister, I call my father, I call whoever it is, and the response is during normal hours, I call so-and-so. If they're not available, I call the next person. And so I go to this action plan when I'm lonely. And then after hours, what do I do? So that there's a mechanism in there to prevent that whole progression to feeling like I want to drive off Niagara Falls, right? And everybody remembers the video from last week where we had the 4-year-old girl that the gentleman met at the supermarket, right? Great, right? And everything he said about how he just was waiting to die. So it's very important, and that can be done by telephone to even have contact with someone so we're not lonely. So any other symptoms? So let's say I'm a diabetic. If I start to feel weak or I start to get sweaty or any of that stuff, what's my response? And generally people who've lived with diabetes for a long time or have these chronic diseases, they can fill that in so easily because they've lived with it so long, they know what works. People who might be new, they might have something else there. But it not only informs them and reminds them, but it informs my sister Jenny, who is the go-to person for making sure that this is implemented and has that available in my electronic personal health record. So it's always available for Jenny to see when the neighbor comes and finds me on the floor and says, oh, here's what she did. Okay, pain. Pain is another one. So the response to pain can be massive. Right? We all, I'm sure everybody in this room has lived with some sort of pain at some point. So if you have osteoarthritis, there might be ways that you deal with that pain. You might use elevation, you might use rest, you might use movement, and you might use analgesics or pain medication. So we encourage that it's not always about medication for pain. Pain can be managed in so many other ways, right? And some people can manage their pain with meditation, or it might be, whatever works for them. So those are the things that are listed here as responses. Now, you're not going into gigantic depth because it might be also in your goals right? And so you don't want to repeat everything, but you want to get the main things in terms of a response. And if it's not in your goals, because it's not a goal or concern generally, it's going to be here and it's going to be fresh. So you'll see kind of the progression from about me, so what's my story, to what do I do when I'm in a state of distress. Urgent care, unexpected emergencies, where do I go? So if my family doctor works during the day or he's not available on weekends, that's who I'm going to go to as my response. Generally it might be, my doctor happens to be Dr. Rajan, he's going to be listed there for normal hours, and then I put my after hours stuff. Clinic Seeker, anybody ever use that? People use the internet? Anybody use the internet? If you use the internet, it's actually, if you go to that site, it will show you the clinics that are in your area and whether or not they're open or closed and whether or not they're kind of at capacity. So what's the wait time? So if it's a 30-minute wait time or a 2-hour wait time. So that can help you make decisions in terms of where you're going to go. EMS, what do I do? So in terms of emergency medical services, if I need to call them for whatever reason, I'm going to make sure that they have a Kool-Aid program, the Kool-Aid form, as well as my plan. So this is just kind of goes down the line in terms of what are the levels of progression. So EMS is always going to be your last resort, unless of course you have an acute injury and you break your leg and you need to call. Chest pain, yeah, that's a good one. And other is just anything else that might have been missed. So that's all going to be discussed and formulated with them. And on page 54, you're going to see the examples of that. So communicating. So I'm going to have you guys break off and do one more session, and this is all on developing your communication plan. It won't take you long to do this because I want to wrap things up in terms of our next steps. So communication we talked a little bit about, but who's my team quarterback? Hopefully we all have one. Some people have actually identified I'd like my nurse practitioner to be my quarterback. I'd like my care coordinator from the LHIN, CCAC/LHIN to be my quarterback because they don't feel that they have anybody else in the area that could possibly do that. Most responsible provider, who's the most responsible provider is usually a physician, it could be a nurse practitioner. And this is where you're going to put your details in terms of how will my team communicate. So it's not just identifying the person, but for example, my team quarterback is responsible for my quality of life plan. I take my sister Jennifer with me on all of my appointments, and Jennifer relays that information to my care team, right? So very point in terms of what I want communicated. If there's changes in my health symptoms, Jennifer, my sister, is going to send that out by email to the following people, right? So I'm going to put that information in there. So you can see these are all just examples in here. So what you see on page 55 just gives prompters for people to use. Another one is my care team will arrange their own huddles to review information and adjust services as needed. So in my example of Jennifer being my quarterback, she might say, okay, all of the Dianes in the room are Diane's care team. Bring them all together and we're going to talk about what they can do Monday through Sunday in terms of setting up the meals because we lost the main meal person. And she might do that through email or have a little huddle over the phone or however it works. Skype maybe. Request for help. Request for help again. So if my quarterback has agreed to do all of this for me, and we hope that they would, Jennifer will send out requests for help to not just the main people on the care team, but now she's going out to the congregation at the church because we don't have enough support here. Diane's been a church member for many years, and we're pretty sure the congregation might be willing to come forward to bring over some soup or whatever, right? So again, who's doing those types of things? So again, that's the understanding of the whole circle of the care, who's in there, who are we connecting to help that support.